Myasthenia gravis is a Latin phrase that translates to grave muscle weakness. It is an acquired autoimmune neuromuscular junction disorder that is caused by antibodies that are directed towards skeletal muscle acetylcholine receptors and muscle-specific kinase. It is a chronic neurological disorder that is characterized by fluctuating skeletal muscle weakness. In most cases of myasthenia gravis, the cause is idiopathic. The prevalence is approximately 14 to 20 per 100,000 population, with a total of 60,000 cases. Myasthenia gravis was previously more common in women. However, there was a shift of incidence and now appears to be more common in men. The pathophysiology of myasthenia gravis involves antibodies and blocked receptor sites. In normal nerve transmission, acetylcholine is produced and secreted in terminal ends of motor nerves. It then crosses the synaptic clefts and attaches to acetylcholine receptors in the postsynaptic membrane. This eventually results in skeletal muscle contraction. In myasthenia gravis, anti-acetylcholine receptor antibodies bind with acetylcholine receptors, resulting in the destruction of receptor sites. Acetylcholine binding is blocked, which reduces initiating depolarizations and therefore muscle contractions. This results in muscle weakness and fatigability. There is an adequate amount of acetylcholine in myasthenia gravis, but postsynaptic receptor sites are not available.
Guillain-Barré syndrome, or GBS, is a disorder of the peripheral nervous system, an acute inflammatory demyelinating polyneuropathy. It affects the immune system and attacks the peripheral nervous system. It often occurs after an infection and leads to a rapidly progressing flaccid paralysis. In fact, approximately 2/3 of patients with GBS demonstrate signs or symptoms of infection 3 weeks prior to onset. Respiratory or gastrointestinal infections are most common sources. Campylobacter jejuni is the most frequently identified cause. On rare occasions, patients may develop GBS in the days or weeks following a flu vaccination. In these cases, flu vaccinations are not recommended in the future. The incidence of GBS is about 1 case per 100,000 people, making it rather rare. Men and women are equally affected by this condition. The pathophysiology of Guillain-Barré syndrome involves the myelin sheath. In GBS, the patient's own immune system begins to destroy the myelin that surrounds peripheral nerves. Destruction occurs between the nodes of Ranvier that impairs saltatory or jumping conduction and results in slowing of impulses or conduction block. There is an infiltration of lymphocytes into the peripheral nervous system, which attracts macrophages. Macrophages penetrate the Schwann cell and invade the myelin, resulting in demyelination. There are 3 stages associated with Guillain-Barré syndrome. The acute stage of GBS begins with the onset of signs and symptoms of peripheral nerve demyelination, edema, and inflammation. It lasts approximately 4 weeks. Demyelination causes the patient to enter the plateau stage. This stage lasts for a few days to weeks. The recovery stage occurs with remyelination and axonal regeneration. There is gradual improvement in patient signs and symptoms.
There are multiple signs and symptoms of myasthenia gravis. Arguably, the main sign and symptom is muscle weakness and fatigue. Along with this, approximately 2/3 of patients with myasthenia gravis present with ocular symptoms, such as ptosis and diplopia. Ptosis is a drooping or falling of the upper eyelid. Diplopia is also known as double vision. The patient may also experience bulbar symptoms, which involves cranial nerves 9, 10, 11, and 12. The signs and symptoms associated with cranial nerves involves difficulty with phonation, chewing, and swallowing. Trunk weakness and limb weakness are also common. Lastly, muscles of the neck, deltoids, triceps, wrists, fingers, and ankles are most commonly affected in myasthenia gravis. Patients with GBS develop a symmetrical ascending motor weakness and paralysis that usually starts in the feet and extends to the trunk and arms. An easy-to-remember phrase is, "It starts in the toes and up it goes." GBS often presents with sensory involvement, resulting in pain involving the shoulders, back, buttocks, and upper legs. Areflexia is a key finding in GBS and involves diminished or absent deep tendon reflexes. There is also cranial nerve involvement. Cranial nerve 7 may cause issues with smiling or frowning, while cranial nerves 9 and 11 may cause dysphagia. If cranial nerve 10 is affected, patients may exhibit autonomic dysfunction. 40% of patients with GBS develop respiratory impairment, and some patients may even acquire paralysis.
Now it's time to recap the signs and symptoms of myasthenia gravis and Guillain-Barré syndrome and distinguish similarities and differences of each. Similarities between the two include muscle weakness and fatigue, cranial nerve involvement, including difficulty with phonation, chewing, and swallowing, and a potential respiratory compromise. Some key differences are that patients with myasthenia gravis may present with ocular symptoms such as ptosis and diplopia. Muscle groups of the neck, deltoids, triceps, wrists, fingers, and ankles are most commonly affected, and signs and symptoms of myasthenia gravis, such as muscle weakness and fatigue, can improve with rest. Patients with Guillain-Barré syndrome may present with paresthesia and pain. Guillain-Barré syndrome can also sometimes result in total paralysis. Guillain-Barré syndrome also presents with ascending symmetrical motor weakness and paralysis that usually starts in the feet and extends to the trunk and arms. Finally, GBS signs and symptoms are unaffected by rest.
The therapeutic management of myasthenia gravis is aimed at symptomatic treatment to increase availability of acetylcholine, immunosuppression, altering the immunopathogenic mechanism underlying myasthenia gravis, and an immunomodulatory effect with thymectomy. The initial treatment of choice for myasthenia gravis is pyridostigmine. It is a 30 to 60 milligram oral medication that is given every 4 hours while the patient is awake. It improves neuromuscular transmission by increasing acetylcholine stimulation of the acetylcholine receptors that are available. It is often given 30 to 60 minutes before meals to minimize difficulty with chewing and swallowing. Neostigmine is another medication given. It is a shorter-acting acetylcholinesterase inhibitor. It is given intravenously when an oral route is not available due to conditions such as Crohn's disease, gastrointestinal bleed, or paralytic ileus. When giving this medication, the IV site should be frequently monitored to ensure patency because of the short half-life of neostigmine. Immunotherapy is another treatment used for myasthenia gravis. It is used when acetylcholinesterase inhibitors are not adequate in moderately severe myasthenia gravis. Prednisone is the principal medication from this category used to treat myasthenia gravis. Additional therapies include intravenous immunoglobulin and plasmapheresis. IVIG is produced from pooled blood donors. It inactivates abnormal antibodies and suppresses T-cell function. Renal failure is a potential complication from this therapy, so it is used with caution. In plasmapheresis, the patient's blood is removed through the arterial lumen and circulated through the plasmapheresis machine, which remove antibodies that block acetylcholine receptor function. Citrate is also added to the blood when it is outside the body to prevent clotting from occurring. It may result in a number of side effects such as fluid shifts, vasovagal reactions, and electrolyte imbalances. The goal of this therapy is to improve muscle strength. Lastly, a surgical approach used for myasthenia gravis may involve a thymectomy. This requires removal of the thymus gland. This surgery is performed in the first 3 years of diagnosis in patients under 65 years old. It is used for patients with a thymoma, which is a tumor originating from the endothelial cells of the thymus. Remember, myasthenia gravis is a chronic disease. It can be managed and patients may go into remission. However, there is no cure.
The therapeutic management of Guillain-Barré syndrome is aimed at supportive care and reducing severity, potential complications, suffering, and recovery time. Although GBS is an autoimmune disorder, steroids have not been found to help speed recovery. Recently, providers have leaned towards not giving patients with GBS corticosteroid therapy. There are two main approaches, IVIG and plasmapheresis. IVIG can shorten the length of the recovery phase by 50% and is recommended for patients who need help to walk within 2 to 4 weeks of symptom onset. It can work by several mechanisms, including blocking of macrophage receptors, inhibition of antibody production, inhibition of complement binding, and the neutralization of pathologic antibodies. 2 grams per kilogram are given over 5 days. Typical adverse reactions include flu-like symptoms. Rare adverse reactions are aseptic meningitis and acute renal failure. Plasmapheresis is recommended for non-ambulatory adult patients with GBS who start their treatment within 4 weeks of symptom onset. It is also recommended for ambulatory patients who start treatment within 2 weeks of onset of neuropathic symptoms. This therapy results in a diminished length of hospitalization and the need for mechanical ventilation if it is initiated within the first few weeks of symptoms. There is an increased risk of infection and hemorrhage as a result of the removal of immunoglobulins and clotting factors. Plasmapheresis can result in adverse reactions such as hypotension, bradycardia, fever, chills, and rash. Physical therapy may be required for patients who lose function and need to regain it. Remember, there is no cure for GBS. However, most patients make a full recovery. The vast majority recover within a year.
Now it's time to recap the therapeutic management of myasthenia gravis and GBS and to distinguish similarities and differences. Similarities between both include IVIG and plasmapheresis therapies, as well as physical therapy. Some key differences are that patients with myasthenia gravis usually receive pyridostigmine as an initial treatment and may also receive neostigmine, immunotherapy, and thymectomy. Meanwhile, while treating patients with GBS, providers often lean towards not prescribing corticosteroids.
Nursing care for myasthenia gravis involves several important factors. Nurses should establish effective communication with the patient. If the patient has difficulty speaking, the nurse should provide a communication board or other sources of communication. If weakness in muscles in hands, arms, or wrists prevent some movement, a soft squeeze call light can be provided. It is important to measure respiratory vital capacity. If the value is below 1 liter, notify the provider. In myasthenia gravis, the patient develops weakness of the diaphragm and intercostal muscles. Weakness of the respiratory muscles result in diminished forced vital capacity. Nurses should routinely assess the patient's chewing and swallowing ability, as dysphagia may result in aspiration. Elevating the head of the bed while eating and drinking and encouraging small bites can prevent this. Monitoring nutritional intake and output, and daily weights are important too. Helping the patient perform range of motion exercise 3 to 6 times a day can help prevent muscle atrophy. A cranial nerve assessment is important to determine cranial nerve involvement and provide care as needed.
Nursing care of Guillain-Barré syndrome involves several important factors. Nurses should establish effective communication with the patient. If the patient has difficulty speaking, the nurse should provide a communication board or other sources of communication. If muscle weakness in hands, arms, or wrists prevents some movement, a soft squeeze call light may be provided. Nurses should also perform a respiratory assessment with vital capacity measurements. Respiratory compromise may require intubation. The provider should be notified if vital capacity value is below 1 liter. Diaphragmatic weakness results in hypoxemia. Nurses should reposition the patient frequently and perform range of motion exercises to maintain joint and muscle integrity. A cranial nerve assessment is important to determine cranial nerve involvement and provide care as needed. Finally, a pain assessment is necessary as pain may be due to sensory nerve fiber involvement.
Now it's time to recap the nursing care of myasthenia gravis and Guillain-Barré syndrome and to distinguish similarities and differences. Both myasthenia gravis and GBS involve establishing effective communication, performing a respiratory assessment with vital capacity measurement, range of motion exercises, and cranial nerve assessment. Key differences are that in myasthenia gravis, chewing and swallowing ability should be assessed frequently. Although this is a good idea for both, oropharyngeal muscles are more commonly affected in myasthenia gravis. In GBS, a pain assessment is important because of sensory nerve fiber involvement. Pain assessments are important in both, but pain is often more common and more severe in GBS.
Some patient teaching for myasthenia gravis involves taking medications as prescribed. It is extremely important to adhere to the medication schedule at home, as swallowing may be impaired if eating, drinking, brushing teeth, and other tasks are not performed at peak levels of medications. And always keep medications with you at all times in case of emergencies. And one should purchase a medical alert bracelet and wear it daily so that they can be identified by EMS providers. And they should avoid public spaces such as theaters and concerts in the winter, where there are large gatherings of people to reduce the risk of catching the cold or flu. And obtain vaccines to prevent flu and pneumonia, as this will decrease the risk of infection. Prevent fatigue with frequent rest periods. And also, do not take over-the-counter preparations without first consulting the provider, because they may contain ingredients such as magnesium, which are contraindicated in Myasthenia gravis. And inform patient and family about resources, such as the Myasthenia Gravis Foundation of America. Some patient teaching for Guillain-Barré syndrome include educating patient and family about GBS at each stage of the illness. This will allow the patient and family to anticipate that respiratory deterioration may occur. Information ahead of time can help alleviate fear. Informing the patient and family about the importance of respiratory monitoring in the acute phase. Provide encouragement that the disease course lasts several weeks to several months, and rehabilitation can assist the patient in returning to pre-morbid functioning. Inform them that recovery is possible. Also, inform patient and family about resources such as the GBS Foundation International.
Now it's time to recap the patient teaching points of myasthenia gravis and Guillain-Barré syndrome and to distinguish similarities and differences. For both disorders, it is important to inform patient and family about resources, educate patient about obtaining vaccines to prevent the flu and pneumonia, and instructing the patient to report new or worsening symptoms. In myasthenia gravis, it is important to instruct patients to avoid public places in the winter, prevent fatigue with frequent rest periods, and to not take over-the-counter preparations without first consulting the provider. Meanwhile, for patients with GBS, it is important to educate patients and family about each stage of the illness and also informing the patient that recovery is possible. Patients may return to a pre-morbid state.
For this presentation, we read an article called Safety of Intravenous Immunoglobulin in the Elderly Treated for a Dysimmune Neuromuscular Disease. Intravenous immunoglobulin therapy, or IVIG, is the use of a mixture of antibodies to treat a number of health conditions, especially neurological conditions like myasthenia gravis and Guillain-Barré syndrome. It can help patients with weakened immune systems fight off infections by replacing necessary antibodies in patients who lack them. The PICO question we formulated for this study is, for patients who received at least one infusion within a 2-year period, what is the prevalence and severity of adverse reactions among older adults being treated with IVIG, compared to those who are less than 60 years old? We evaluated the strength of the study's results by asking several questions. What kind of study design was used? This is a retrospective cohort study, which is a moderate strength design, number 4 out of 7 on the hierarchy of evidence for intervention studies. This kind of study yields more evidence than systematic reviews of qualitative or descriptive studies, and expert opinions. However, it typically yields less evidence than systematic reviews, meta-analyses, and randomized and non-randomized controlled trials. How large is the sample size? This study had a strong sample size of 244. Is it peer-reviewed? This study is peer-reviewed. How long ago was it published? This study was published within the last 5 years in 2016. And are the authors qualified? The authors of this study are qualified and all have an MD, PhD, or both. Based on all of these factors, I would rate the strength of the study's results as moderate to high strength. Are the results valid? This study has high external and construct validity with high generalizability. It has moderate internal and statistical validity due to the limitations of the study design. Did the study use a randomized controlled design?
No, this is a retrospective cohort study. Looking at the hierarchy of evidence, how strong is this study's design? This is a moderate strength design according to Melnick and Feinout-Overholt's hierarchy of evidence. What are the study's weaknesses? For one, the study did not allow for the evaluation of the specific impact of administration modalities on the safety profile of IVIG. There is no control group, therefore it cannot be determined whether the adverse reactions are definite side effects. However, the occurrence of similar events in randomized studies suggests that the results accurately reflect side effects in the elderly treated with IVIG. The authors could not draw a definitive conclusion on the safety of sugar-free IVIG, but adverse reactions were significantly more common in patients treated with sucrose-free IVIG, regardless of age group. Time of infusion and IVIG concentration were highly correlated, therefore the independent effects of these two variables could not be evaluated. We can use the study's outcomes in planning nursing interventions related to IVIG administration and monitoring. For example, based on the study's results, we know that IVIG is generally safe for adults older than 60, but sugar-free preparation should be used with caution in the elderly and those with renal susceptibility. In addition, it is important to properly hydrate patients before infusions, to infuse at room temperature, and to provide preventative therapy against adverse reactions. Other considerations for nursing interventions related to IVIG include sucrose-free IVIG preparations increase the risk of immediate adverse reactions, and sugar-stabilized IVIG can cause eczematous skin reactions. Although it is generally safe in older adult patients, the expected benefits should be weighed against safety, and special attention should be paid to the maximum IVIG daily dose. Known risk factors for intolerance include age, hypertension, diabetes mellitus, and others. DVT and acute renal failure are the most common delayed adverse reactions. Other adverse reactions include aseptic meningitis, intractable hypertension, hematological disorders, and more. In addition, higher daily doses are associated with increased blood viscosity and risk for DVT. Finally, administering a total daily dose of greater than or equal to 35 grams, using sucrose-free IVIG or 10% concentrated IVIG, and having the presence of greater than one risk factor were all associated with a greater risk of adverse reactions.